Hi, welcome to All Things Odd. I'm Dr. Natalie Phillips.
I'm Dr. Hannah Galloway.
All right, and so we have a really cool topic to talk to you about today. But before we get there, we're going to just review our YouTube channel. So I'm going to have Dr. Galloway do that real quick.
Yes, so if you go to YouTube, you can see there that these are all kind of like the thumbnails, and there's different playlists of our show on YouTube. So we're always looking for more subscribers. So you can go on there and subscribe, and then it'll give you notifications when we have a new episode. We don't have a new episode every Thursday, but most Thursdays we do at 12:30 Mountain Standard Time. So that's when they'll pop up. But it's just kind of a nice way, a different way to look at it than Facebook.
All right. And so we have a really cool topic today. And I'm not too sure if you guys have heard about this, if you've seen people and have talked to people that have this particular thing that we're going to talk about. And what we're going to talk about today is called superior canal dehiscence syndrome. So SCDS for short. And so I'm going to have Dr. Galloway talk a little bit more about what it is for us to start off.
So also there are way too many acronyms for this condition. I use the acronym SSCD, Superior Semicircular Canal Dehiscence, but there's all kinds of different acronyms, so you may see more than one. But yes, this is a very interesting condition. And I meant to look it up. It has not been in the diagnostic manual for that many years. So it's a relatively newer condition. But yes, so the symptoms of superior semicircular canal dehiscence are things like hearing yourself really loud, hearing your internal body noise. So being able to hear your eyeballs move or your footsteps, or when somebody uses a reflex hammer on your knee, hearing that super loud on your ear on that side. And so it's very sort of interesting symptoms. And people, a lot of times, one woman that I saw, I said, "Do you hear your eyeballs move?" And she said, "I never tell anybody that because they'll think I'm crazy." But she totally related to that because that is something that she's seen or that she's experiencing. So it has sort of a unique host of symptoms, and it can kind of be muddy as far as what's going on. So we test for it in our office, and we thought we would just give more information on that condition today.
Yeah, and we did want to say hello to some of our colleagues that are tuning in. So as you're tuning in, please put in the comments where you're from, if you have any comments, or if you've experienced superior canal dehiscence syndrome, or if you've had patients, right? And so what was kind of interesting, so hello, Blaze, good to see you, and our friend Noelle, great to see you as well. So thank you guys so much for tuning in. So what's interesting really is this, and we've got some pictures that we're going to show here. So that superior canal dehiscence, Dr. Galloway had brought up this topic, and I thought, oh my gosh, we should talk about what it is and what it isn't. Because I do want to say there was an episode long ago on ER, and I couldn't find the actual clip, but it was a woman that came in, and actually it was played by Demi Lovato. I don't know, I have no reason why I remember that, but I do remember it was in the comments. Yeah, it was in the comments of one of our audiology groups. And she was the patient in the ER, and she complained of hearing voices in her head. And they were trying to figure out if she was schizophrenic. And then she said, oh, she has superior canal dehiscence. And the whole audiology community was like, no. So anyway, I wanted to talk about really quickly, and some audiologists that are watching too, you might remember that. But I remember it being all over the audiology boards because we're like, no, that is not what it is. So I did want to say what it isn't. And it isn't necessarily voices in your head, but it's exactly what Dr. Galloway was saying, is sometimes it's like if we tap on your knee, you can hear your eyes rolling in your head, you can what it presents as, we'll talk about what it presents as when you come and see us as audiologists. But basically, it's this thinning of the bone that we're going to show you what it looks like too. We've got some great pictures. It's that abnormal opening, between one of the semicircular canals, which there's 3 of them, right? But it's that top part, which is the superior part of the canal. And really, it causes that hearing. It shows up as sometimes a hearing loss, and then also some balance issues as well. And so some of the causes are sometimes you're born with it. It's just something with the fetal development, and it's just not necessarily, it hasn't formed correctly. The other major thing that we've seen, because we work with a brain concussion specialist, is sometimes it's accidents or trauma that can cause it as well. And sometimes it gets worse and worse and worse as it continues to thin. And so some of these symptoms that Dr. Galloway talked about, they can be intermittent, they can be constant. It just kind of depends. But you hear that those internal sounds, your own voice, not other voices, but your own voice, chewing, eyes moving, footsteps, things like that. And hearing oneself, there is a term for that, and that's called autophony. So AUTOPHONY. And so there is actually a term for that, of hearing your own voice in your head. And so some of the things that we notice when we are taking history, especially the patients that come to us from our concussion specialists, is we always ask are you hearing any kind of your voice or anything in your head as you speak, like an echo of your own voice? And so that's something that typically is what people say in those symptoms. Yeah.
And also the eyeballs moving. I mean, that is, you ask 90%, 99% of your patients that, and they say, what do you mean? No. Like blinking? Can I hear blinking? Like, no. Can you hear it when your eyes go that way? No, that's not a usual thing to hear. So that one is pretty indicative for patients. And we'll show a diagram here in a little bit, but so essentially there's the semicircular canals, there's a really, really thin shelf of bone, and then above that sits your brain. And so if that little tiny thin shelf of bone either wears thin or breaks from trauma, the sound actually escapes out the top. So you can see on this semicircular canal, if that little shelf of bone right above it is thin or absent, the sound actually escapes up there. And since there's a hole in the bone, it's going to be more heavily low frequencies. Sorry if this is getting dense for any of the non-audiologists watching. But so the low frequencies are what's going to be the most noticeable, right? Because those are escaping out that hole. And so it's your own body noise and the physiologic noise that you're most likely to hear. Because number one, your eyes are very close to your ear right there. And if there's that third window effect or where there's that hole, the sound escapes out the top there. And then your head is quite literally filled with your own voice or your physiologic sound.
Yeah. And I love these diagrams. There's a couple of different diagrams on what they look like. I know that the top one looks more like the thinning of the bone above that semicircular canal, but it's kind of a misrepresentation because the canals are kind of embedded into the bone. They're carved into the bone. It's not like there's a structure and then there's a bone over it. So a little bit, that top thing, the top picture is showing it just a little bit off. I think the bottom left is a little bit better. And then we've got a scan here. So if you were to actually do a CT scan, which will look at the bones, you'll see that thinning where the arrow is pointing, that thinning of that bone where the semicircular canals are actually kind of, and it's not really embedded, but it's kind of carved out into the bone, basically. And so that's what we're looking at here. So a little bit of misrepresentation, I'll tell you, but it's a great way to look at what's happening.
And to understand the general anatomy, because obviously these structures are so small. The bones of the middle ear that you're seeing right there that are purple, those, all three of them can fit on half of your pinky fingernail. So what we're talking about is so small that really any picture is not going to represent it well. You see in the bottom right, that's a CT scan. And so if you did have superior semicircular canal dehiscence, ultimately you would have a CT scan on both sides to see it. And they order the scan at such high resolution that they can see this tiny little piece of bone that's in question. And years ago, they couldn't even do that because imaging wasn't as good. So we didn't have this diagnosis. We didn't have a way to really look at it very well because of imaging. And so the CT imaging has gotten a lot better. And so that's ultimately what a physician is going to be looking at to figure out, yes, this is definitely what it is, even though we had a really good idea from these other diagnostic tests. But then what are we going to do with it? Can we resurface or what can we do?
Yeah. And super interesting. So again, typically what we would hear as an audiologist with a patient coming in would be maybe a hearing loss, distortion in the hearing, dizziness, like even when you're bobbing your head, or, we talked about that low frequency conductive hearing loss that we see sometimes when we do a hearing test. We see also sometimes when people sneeze or cough,
pressure
they might have that dizziness as well. And then Tullio's phenomenon, which is also that, if there's a certain tone of your voice, or a music listening to, you're listening to a certain music, like that can make you dizzy too. So kind of interesting. There's a lot of different things that are out there. Yeah.
And a lot of the patients that we see where this is a possibility, they've had a head injury. So they're dealing with post-concussive symptoms. But in our previous ENT practice that we worked in, we would see people that would actually just come in with complaints of like, hey, I hear my own voice really loud on this side, or hey, there's something, going on. I remember a patient that we had that was in her 90s and she wasn't going to do anything about it, but she felt crazy because nobody related to this. Nobody understood this. She had had a diagnosis of Meniere's disease because she was in her 90s. It had probably been, decades past that she'd had that diagnosis, which was not correct. And anyway, just letting her know that, yes, this is a real condition and this is what happens to people when they have it. That was really reassuring for her. And she even said, I'm not going to do anything. I'm, 92, but knowing that this is a real thing and it really presents this way, I think gave her a lot of confidence.
Yeah. Yeah. All right. So kind of how do we diagnose superior canal dehiscence? Typically when, again, like we get a lot of patients that have come in with trauma, right? We talked about how some causes are from the lack of fetal development as well. But one of the first things we do is we run a hearing test just to see if we see any trends in that low frequency conductive component, conductive hearing loss that we do. And then we also do a vestibular evoked potential test, which is called a VEMP test. And so that's kind of taking a look at how we are eliciting a response from the neck muscles contracting, and you're looking at the eye muscles as well. And so that is the audiology part of it. And then we have them sent to neurologist or neurotologist, I should say, ENT, to do the scan, to kind of take a look at that as well, to confirm if that's something that we see in some of our results. And so low frequency conductive hearing loss, and then there's certain things in that VEMP study, the vestibular evoked myogenic potential, where there'll be a huge amplitude. And what we're looking at is a waveform for people who are not audiologists tuning in. And we're looking for a big amplitude as well as a very low threshold, where we try to take it down as low as possible to see if you're still eliciting that response based on that neck muscle contraction.
And if you're an audiologist listening and you do VEMPs, so we are currently just doing cervical VEMPs. We've done ocular VEMPs in the past, but that's not something that we're doing right now. So we are finding, abnormalities on the cervical VEMP. And if you've never seen one on a VEMP, it's the amplitudes are a lot bigger, and you can usually get it like a lot lower than 70. So coming out of grad school, I thought, okay, if it's going to be like a 65 threshold. No, it gets lower than that, and the amplitude gets a lot larger. So if you're sitting there questioning, I wonder if this is SSCD, it's probably not if you're thinking about it that hard, because the first couple ones that I saw on a VEMP, it's like, whoa, that's really, that amplitude is really high. So that's just my kind of 2 cents on if you're running a VEMP and you're thinking, like, is it splitting hairs? It's not. It's a big response in the ones that I've seen.
Yeah. So the nice thing about heading to an audiologist first, if you're having some of the symptoms that we're talking about, is we can do some tests that are a lot less inexpensive to rule it out for you. And if we do see something, we'll pass it on, and then they'll order the CT scan to confirm. So that's typically the way that it works in the diagnosis part of superior canal dehiscence. All right. And then we are going to talk about the treatment. So I'll have Dr. Galloway talk about that. We've got this really fun video for you to watch as well.
Yeah. So we have a video that we're going to watch. We currently, if we identified a patient and we thought, I think they have SSCD, we would refer down to our neuro-otology clinic. We work with Dr. Kelsall and Dr. Lupo at Rocky Mountain Ear. And the one that I did find, since we've been in our new clinic, we did send down to Dr. Lupo, and he was able to take care of that. But there's a procedure called resurfacing, and the physicians are going to talk in this video and probably be a more reliable source of information just on the actual surgical procedure itself. But what I know is that it's not something that's done by every, ENT around. It's a more specialized procedure. So you really do want to go see a neuro-otologist. And I'm under the impression that not all neuro-otologists do this kind of procedure. So I think it might only be done at like certain clinics or hospitals. I know that Dr. Lupo said that he would see a patient with this. So that's who we're referring to. But it's a procedure called resurfacing, where they're essentially trying to plug that hole where you have that sound escaping. So we'll put the video on, and it's a patient talking about her experience with the condition, and then also some physicians talking about the procedures.
Hold on. We're having technical difficulties.
Yeah, I don't think
there it is.
Really wasn't going to be.
Okay, let me start this over again. Okay.
So I was having really bad vertigo, and at first I went to my pediatrician. They told me basically you probably just have benign positional vertigo, it'll go away in a couple days. It didn't go away. So my mother booked appointments with a bunch of ENTs around Boston, and one of them just happened to be Dr. Lee. I didn't feel right. I didn't know exactly what it was, but my ear kind of hurt a little bit. My stomach felt a little upset. And so I just went home and just kind of rested. Then I woke up the next morning and the whole room was just spinning around and tilting. And that's kind of when I knew that it really wasn't going to be okay. It definitely affected my daily life. My grades in school dropped a lot.
Okay, hold on. We're going to look for another video because I think this is not the correct
Yeah, that's
one.
not the one that I vetted a video earlier that was a couple minutes long, but it interviewed the patient and the surgeon. So
okay,
I don't want to keep watching that live because I don't know where it's going to go. This is it.
Okay, got it. All right, so here we go. We're going to put this back in. Okay, thanks for hanging with us, you guys. This is really cool.
We could have taken you down a weird path. I don't know where that other video is going to go. So
okay,
this one we like.
Fixing an afternoon snack is something most of us think very little about, but for Rachel Pine, it can be excruciating. Rachel can not only hear herself chewing and swallowing food, but her body digesting it. She's actually heard her eyes move as they scan a magazine. And even when she tries to find peace and quiet, the noises never stop.
I can hear my heart beating and it's like thump, thump, and my whole ear goes out. It feels like my whole ear is beating with my heart.
Rachel suffers from superior semicircular canal dehiscence, or SSCD. The bone between her inner ears and brain developed tiny holes that caused huge problems.
When you start to hear noises that you shouldn't all the time, it gets to be very distracting to the point where you can't concentrate, you can't sleep, you can't function.
Along with the noises, Rachel began losing her balance and suffering debilitating dizzy spells. She saw 9 doctors with no answers. Then she learned the only cure was opening her skull to plug the holes in her inner ears. In the past, that surgery meant big scars and long recoveries. So Rachel traveled from her home in Indiana to Ronald Reagan UCLA Medical Center, where doctors have pioneered a new approach that results in a shorter surgery, smaller scar, and faster recovery.
What we do now is we do the whole surgery in an opening the size of a dime.
And they do it with remarkable technology. To find an opening in a bone smaller than the head of an ink pen, doctors at UCLA map the brain, then use GPS-like technology to pinpoint the hole and seal it with filler.
It's like a heat-seeking missile right for the itty-bitty hole that's between the ear and the brain. And so that lets us find the needle in the haystack.
And give patients immediate relief.
They're just shocked. I think there's very few things that are that instantaneous, and they go to sleep, and when they wake up, it's gone, and they're very happily surprised.
When I woke up, I just thought, oh my gosh, it's gone.
At Ronald Reagan UCLA Medical Center, this is Clark Powell reporting.
Oh man, was that good?
I hope they were hearing that. I just see that Amit said no sound.
Oh yeah, that was back when I started the other one. Okay.
Perfect.
So what's cool about this is, I mean, you look at this woman who has kids and can barely probably even move her head without noticing some either dizziness or hearing some weird echo. And I think what hit me the most was when she said that she had been to 9 doctors and did not have an answer. And so that's why we wanted to kind of talk about this too, because we wanted to show that, okay, hopefully other people won't have to go through 9 doctors now that you're watching this, or you can look it up on your own as well, to please pass this on to people, and to learn a lot more about them. So again, many of our colleagues that are on here commenting as well, they know all about it, but it's hard because sometimes I think that obviously the consumers don't know as much. And so we're trying to make this as educational as possible to make sure that it can be passed on so that people are not running around to 9 doctors. Cause I would be really mad if by that time, and maybe even give up and feel like I would have to just deal with it for the rest of my life.
Well, and we know as audiologists that when we don't have a reason for vertigo, it's essentially anxiety related, right? There's an acronym for that, and I always mess it up. It's like PPPC or PPPD, post-perceptual I can't remember. But anyway, it's essentially the bucket that everybody falls into when we can't find a reason for your vertigo. And unfortunately, when you think, well, this could be anxiety related, anxiety can manifest a lot of things. Mental health problems can manifest a lot of things. And so like my patient, she just felt validated to know that she's not crazy. It's not crazy to hear your eyes move. There's a medical condition that causes this. And so I can imagine, especially a primary care doctor, they see a lot of patients in a day. Having such a specialized issue, they might be like, what? I don't know. They might not know what's the appropriate referral. And even an ENT doctor, they're going to know more about it, obviously, but they're not the physicians that are treating it. So it is just so specialized that a neuro-otologist, most people don't have one of those, in their call log. So we definitely can find somebody to refer you to. But yeah, it is so specialized that I think it's just really validating for patients to hear that, you go to 9 doctors, you probably would start to feel crazy because no one knows what's wrong with you and they're just passing you off to the next person.
Yeah, absolutely. All right. So hopefully this kind of gave you guys some information. We'll kind of recap it as people are coming on and checking this out. But I wanted to say hello also to our good friend, Dr. Amit Gozalia out in California. And then our buddy just up the road, up the mountains in Estes Park, Dr. Corey Workman as well. So glad to have a lot of colleagues jump on here. But superior canal dehiscence is something that can be treatable. You can start at an audiologist, right? You can start at an audiologist. And so, we would do some tests that would then send you over to have a scan. You don't have to start there. And sometimes we can weed out if it's not superior canal based on some of the testing that we do. It might be something else that's related to the ear, or not every vertigo symptom is also ear related. And so we're a definite good first stop for people to get all of that done, and that we can help you with the diagnosis and then pass you on to some of the other professions and professionals and physicians or other colleagues that might be able to help you. So definitely it's not the end of the road. You can start with an audiologist for sure. Anything else that we can kind of talk about?
No, yeah, it's an interesting condition, and the magic of the internet is great. I had a patient come to me yesterday for a totally different condition, but she researched it online and said, I identify with all these symptoms and I just want to see if I have this. So the internet is a magical place. On YouTube, I was looking for a video that I watched in graduate school that was a testimonial of a patient before she has surgery and then after. I wasn't able to find that, but when you search SSCD patient testimonial or superior semicircular canal dehiscence patient testimonial, there's all kinds of stories from people. And so I think that's awesome too, just for patients to listen to that and go, okay, yeah, that I totally relate to that. That's what's going on with me. I'm going to go get this kind of checked out.
Yeah, absolutely. All right. So if you're just catching the replay, then put on the comments. Okay, yeah. So Dr. Amit Gozalia is asking.
Yep. So he's asking, what are the audiological test results? So conductive hearing loss, usually low frequency conductive hearing loss, they don't always have to have that. The big one is just the cervical vent. You find a low threshold, so a threshold below 70 dB and a high amplitude, even at that low threshold. And so that's kind of the big criteria that we're looking at. And then we're, referring to neuro-otology, saying suspected, SSCD, patient complaints of whatever with a vent that's abnormal.
Yeah, I would say history. So asking them about, if they're hearing that echo, the conductive hearing loss. And I have to say conductive hearing loss sometimes can be in one ear. So the conductive low frequency hearing loss is what we look for. Sometimes it's one ear, sometimes it's both, but one ear. And then the cervical vent with that high amplitude of over 400 or 500 microvolts even, and then lower than a threshold of 70 decibels that we're presenting at. So that's what we find if you walk into our office. So thank you for that awesome question.
Well, and I'm going to add on that with conductive hearing loss, audiologists know if you have normal air conduction thresholds, sometimes you don't find a conductive hearing loss unless you're looking for it, So sometimes if you have normal air conduction thresholds and then, your bone line is coming in like 10, 15, it's like, oh, that matches up. But it could be a bigger conductive loss if you're actually looking for it or going, super, super low with your bone. So that's something we have seen patients that had a normal hearing test elsewhere. And it wasn't anything bad on the audiologist that did that hearing test. It was within 10 dB. But then when I suspected SSCD and I put the patient back in the booth and then really looked for a conductive hearing loss, first of all, I went down lower to 250 to do bone, but also audiologists know what I'm talking about. There's just sometimes if you're looking for it, you can
Mhm.
find it. And so with this patient, I was able to find a conductive hearing loss, but it wasn't immediately obvious when they did their primary hearing test.
I'm so glad you brought that up because that's huge. That's
Yep.
huge because they could present with normal hearing
Right.
and you want to make sure you're doing that conductive, that bone conduction line correctly. But again, that kind of prompts me as I'm doing history. Like I always
Right.
ask that question, right, about the echo. And if they say yes, then I definitely pay a lot more attention
Mhm.
to that. Or if you already know what their symptoms are. So I'm glad that you brought that up because it could
Yeah.
present air conduction wise as a normal hearing loss or a normal hearing.
Right. So then you're like sort of
Yeah.
not really seeking any further.
Yep.
Oh, the hearing's normal and they have vertigo. So this is totally unrelated. But
Yep.
then knowing, okay, the vent is abnormal, we go back in. Many of you may not routinely do bone at 250. We don't. We do bone at 500 routinely, but going down to 250 and then looking at the air bone gap because you're not having hearing loss. So technically
Mhm.
hearing is still normal, but it's just an abnormal air bone gap. So testing wise, that's something that would be super easy to miss.
Yeah. And so one of our other colleagues here is saying, Dr. Workman says, we had a patient identified at an ENT office with
Mhm.
dizziness during a tympanogram. Yes. And so what's happening
Yep.
there is what we talked about, right? That pressure induced vertigo, where it's a phenomenon, right? Where you have that pressure, whether you sneeze, cough, with a tympanogram.
Pneumatic otoscopy. We used to do that at the other office. So
Yep.
you do the little pneumatic bulb while you're
Mhm.
doing otoscopy, and that can also provoke it. But if you're an audiologist doing tympanograms routinely
Mhm.
and you got the history, then you can go look at their eyes while you're running your temp to see if they're having any
Mhm.
nystagmus.
Yep.
But again, if you didn't have the history, this is all something that you would not be looking for
Right,
because it's kind of weird, unless they're coming to you saying that they're having these specific symptoms.
Yeah, awesome. Thank you, Dr. Workman, for
Yep.
bringing that up too, because that's a huge test that we could do as audiologists.
And
to
that's
see.
something that if you don't have VEMP, if you're not doing advanced diagnostics in your office, but you're thinking, okay, well, this might be what's going on, that would be something to just check with the machines that you already have in your office.
Yeah, awesome. Awesome. Well, thank you to our colleagues that tuned in. Thank you for your input as well and making this more of a conversation because that's what we want to do. This is why we do it live. So with your questions, with the tests, and we are going to sign off. I'm just going to put this one more comment up too, just to make sure that it gets into the show too, with Dr. Workman talking about the patient that they had found with their symptoms. So again, we love the collaboration that we're able to have with a live show like this. And so thank you guys for posing your questions, also collaborating to this actual show to get more information out to more people. So with that, we will be back next week with a new episode. Stay tuned and we'll see you next Thursday. Thanks for tuning in.